Thanks, guys, for having me. So I'm Dave Blauvelt. I am a pediatric critical care physician here at Nemours in Delaware. I also have a lab here studying various things, but all related to extracorporeal life support, trying to make it better for our patients. And so today I'm going to be talking about a project I started when I came here in the fall with Tom Schaefer, looking at perfluorochemical therapies for liquid lung rest in extracorporeal life support. So as a little bit of a, well, I guess I should say that this is going to be very similar to the grand rounds I'm going to be giving next week. So if you guys have any feedback about the presentation, that'd be really helpful. Because this will be, I'm giving a joint talk with Tom, and this will sort of be my half of it. So in terms of a little bit of background of what we're going to be talking about today. So first, I'll be touching on what pediatric ARDS is, or PARDS. I'll also be giving a little bit of background on what extracorporeal life support is and how it works and why it's important. And then along with that, introduce the concept of lung rest for ECLS. And then after that, I'll be talking about kind of the work that I've started here, which I now term liquid lung rest, which is sort of a new concept that I'm trying to develop. I'll talk about the rationale for why we would think about doing liquid lung rest, and then talk a little bit about some of the early results that I've gotten in the studies in the lab. So I thought I'd start with a case, actually. This is a kid that I actually saw in like the late fall / early winter last year. It's a 9-year-old who presented with a pneumonia. And his course was relatively standard for pediatric ARDS, but on the severe side. So he presented with respiratory distress secondary to a bacterial pneumonia. He was originally not super sick, was on the regular hospital floor, but then worsened and was fairly quickly intubated after transferring to the ICU. And so this is actually what his x-ray looks like. And so for those of you who are not familiar with looking at chest x-rays, this area, these are the lungs here, and this should be black because it should be filled with air. You can see there was all this white here. That's all pneumonia, fluid. It's not good for breathing. This here is the endotracheal tube, and you can sort of see the airways. This big bubble here is a stomach bubble. And actually this air in the stomach is kind of looks a little bit more like what the lungs should look like in a normal patient without ARDS. So this patient actually further escalated and continued to worsen. So he was eventually put on extracorporeal life support, which is essentially a heart-lung machine providing gas exchange outside the body. And it's simply because his lungs weren't working well enough to provide enough oxygen and CO2 clearance to survive. So he was actually lucky. He spent just 5 days on ECLS, recovered well enough to come off, still stayed in our ICU for several weeks, I think, before he was able to be extubated. And then he spent a really, really long time in the hospital rehabbing, and was in the hospital for nearly 4 months before he was discharged home. So this patient had pediatric acute respiratory distress syndrome, or PARDS. The severe forms of PARDS are associated with a high mortality rate, really sometimes upwards of 40% in the most severe cases. The basic physiology of it is it starts with some sort of injury to the lungs, whether it's pneumonia, which is fairly common. You can also have systemic diseases like sepsis, which can cause injury to the lungs indirectly. Also, things like trauma or aspiration of stomach contents can lead to ARDS. What happens is when you get this lung injury, then you eventually progress to inadequate gas exchange, and then you get hypoxemia, which means low oxygen in the blood, acidosis, which means that your blood is more acidic because you are not clearing enough CO2, and then ultimately this causes multi-organ failure and death. So to kind of break the cycle of PARDS, this extracorporeal life support is used for the most severe forms of pediatric ARDS, and as I mentioned, it's essentially an extracorporeal heart-lung machine. So this is a diagram of what it looks like. This is a a neonate that would be on it. What we do is we place these large catheters in the neck, sometimes one, sometimes two, and it draws out deoxygenated blood through a pump, usually a centrifugal pump, pumps it through an oxygenator, and then in the oxygenator, the blood interacts with sweep gas, which is a mixture of oxygen and regular medical air. And then that oxygenated blood and this, CO2 is also removed in the oxygenator, and this sort of now blood that's been oxygenated and removed of CO2 goes back to the body. And so essentially it does the function of the lungs and sometimes the heart. So the advantages of extracorporeal life support is one, you can normalize your gas exchange values in severe ARDS when the lungs are not sufficient to do the job. And the other big important advantage is it allows the lungs to rest and recover. And this concept of lung rest is really hinged on the fact that mechanical ventilation can further injure damaged lungs. It's this concept that's been around for decades, this idea of ventilator-induced lung injury, that when you use high pressures, which are necessary to support gas exchange in the injured lung, this can actually further exacerbate the problem and lead to more injury and sort of lead to the cycle that eventually leads to death. And so what ECLS does is it allows us to turn down the ventilator to what we call rest settings, which are very just low settings because the device is doing the work, so you don't need the lungs to do the work, and so you don't need to beat up the lungs when you're on ECLS. But although this concept has been around, nobody really knows what the optimal lung rest settings are. So this is some data that I gathered a couple years ago using the Extracorporeal Life Support Organization database, which just looks at what people do. What do physicians do in terms of setting the ventilator? And you don't need to know what all these necessarily mean, but some of these are relatively straightforward, like respiratory rate. This is how fast the ventilator gives breaths. This is how much oxygen is used. But suffice it to say is that there's kind of a variety. There are some commonalities, like people oftentimes will use a positive end expiratory pressure or a PEEP of around 9 to 11, which really tends to be about 10. Most people will use a delta pressure of so 10 above PEEP, 9 to 11 above PEEP. But at the end of the day, there's a lot of variety in terms of what people actually use, and there's really no evidence-based guidelines for what we should use for the ventilator. And on top of that, we don't even know whether gas exchange or gas ventilation is the best option. And this is where liquid lung rest and this concept has come. The idea that maybe actually using liquid is better than using gas to rest the lungs. So the idea is based on a couple of principles. So one is that you don't really need the lungs to do work when you're on ECLS, assuming your device is working well. And so you can do sort of whatever you want. You can fill the lungs with liquids, which normally may inhibit efficient gas exchange. But in a patient who's on ECLS, you don't necessarily need gas exchange in the lungs, and you really just want to do what's best for healing and recovery. The second thing is that one critical feature of pediatric ARDS is that there's uneven damage to the lungs, an uneven distribution of air in the lungs. And this is called, this can cause things like overdistension of some of the alveoli or the lung units of the units of the lung and collapse of others. But this is a graph of something that was actually shown back in the 1930s. It was then republished again in 1971 in the New England Journal of Medicine. This is a very famous physiologic diagram that just shows what happens when you inflate a lung with either air or saline liquid, so either gas or liquid. And so the key piece of this to know is that when you inflate it with liquid, you can actually use lower pressures and get bigger volumes. And so the lungs tend to be more compliant and more evenly evenly opened when you fill it with liquid as opposed to gas. And that's the idea, is that what we want to do in resting the lungs is we want to fill the alveoli to their resting state, and not more and not less. And we want to fill it evenly. And that's the idea behind liquid lung rest and why it may be better than gas exchange or gas lung rest. So the hypothesis of the study is that PFCs, perfluorochemicals, will enable gentle opening of the injured alveoli to their resting state. And this will then translate into histologic and biochemical evidence of less lung damage and inflammation. And we chose perfluorochemicals because these have been used in liquid ventilation in the past. They're known to be safe, and they're very inert. And on top of that, they can actually perform some gas exchange if necessary. So the design of the experiment is that, so it's a pig study. So what we do is we induce a lung injury with oleic acid, which can cause a very severe lung injury when injected IV. It's a animal model that's been around for decades and is very well established. Then we place the animal on extracorporeal life support, and then we randomize to either lung rest with or without PFC, so either with just gas ventilation or with ventilation with additionally with perfluorochemicals. Then we're going to monitor the animal for 4 hours. At the end of it, we're going to do histologic evaluation. And throughout this, we're going to be taking measurements. So we could take so we were going to look at pulmonary compliance, and we're also going to look at serum cytokine levels. We're going to look at the baseline before any injury, post-injury, and then every hour until the end of the study to look at see if there's any change in cytokines over the course of the study, as well as pulmonary compliance. So the data is thus far. So the first thing we had to do is to establish the pig model on ECLS. This had never been done at Nemours, and is a relatively challenging animal model to do. It's fairly complex to actually place a pig on ECLS. And so this is what it looks like. This is kind of what our experimental setup is. This is the cannula that goes into the neck. It draws blood out of the body. This is the pump here. And then this little small thing here is the oxygenator. It interacts with, you can't see it off of the screen, but there's some gas tanks over here that flow oxygen into it. And this blood, you can kind of tell that this blood is a little darker than this blood. This is kind of the reoxygenated blood that's going back into the body. It may be a little bit tough to tell a bit of this picture, but these two are different in color because this is deoxygenated blood and this is oxygenated blood. And so we wanted to establish the model where we can show consistent injury over the 4 hours and make sure that the compliance is actually of the lungs is going down. So compliance means how much pressure it takes to open the lungs. So the lower the compliance, the stiffer the lungs and the more injured they are. So if you look at this graph at baseline, these are just two different forms of compliance measurements, static versus dynamic. I won't really go into what the difference is in, but there's basically just two ways to measure compliance in the lungs. If you look at baseline, it's sort of between around 1 for dynamic and 1.5 for static, and you can see a big drop after the injury, and then it keeps dropping as the injury keeps getting worse over the 4 hours. And so we felt after a couple of pigs that our model was quite good. We were able to support the pigs and keep them alive for the 4 hours and demonstrate continued poor compliance and a severe lung injury. And thus far, we've done 7 pigs in the study, 4 in the gas ventilation arm and 3 in the PFC arm. And this is the data thus far. So we do actually see a difference. So this is the baseline. There's no difference between their baseline compliance. There is actually somewhat surprising. It's probably just due to the numbers. There is a slightly difference in that the PFC arm actually had a larger injury based on compliance. And despite that, you get a nice bump in your compliance. Of course, you're not going to go back to baseline because the injury is quite severe, but you get an improvement in your compliance that's statistically significant. And then in the gas ventilation arm, you're having a decrease over 4 hours. And then, so this is, I think, the compliance data is encouraging, especially since we're seeing it early, even over 4 hours. Patients are oftentimes on ECLS for days to weeks. And so the hope is that this trend will start to split more and you get better rest and better recovery with PFC versus gas. But we'll find out. That will take sort of longer term studies in order to sort that out. Then I just want to show you a representative. We haven't done all the histologic evaluation, but this is actually fairly representative of what I've seen so far. This is what the lung looks like in gas ventilation. So this is very abnormal. So the white space here is air. And so most of this should actually be fairly open with very thin alveoli. You can see there's all this thick injured alveoli very little white space, very little lung tissue that is normal. Here, this is also not quite normal, but you can see there's much more white space. The lungs are more open, and I sort of attribute that to the PFC kind of opening up the alveoli. But again, this is really not fully analyzed. This is very preliminary data so far. Want to talk about some of the timeline for the work. So the study that we're doing should end sort of end of the summer, early fall. I want to do another study looking at the dosing optimization to look at how much PFC is the best to actually achieve the best lung rest. And then, of course, I talked about doing a longer term study. So, we want to really see this beyond 4 hours to see if the early effect that we're seeing it either goes away, which would not be ideal, but necessary to know, or it gets even greater in terms of you get even better separation between the groups in a multi-day study. And then, thinking about potentially going to a pilot clinical study in a couple of years to look at this actually in humans. And so that's what I've got for this study. Just want to acknowledge some people on my team, Anne and Tom. Prasad's an associate in the lab. And then, this would not be possible without a host of respiratory therapists and nurses that have really helped with the study. And then, of course, funding from Scott Weiss and David Brousseau and hospital leadership. So thanks so much. If you have any questions.